Friday morning again. It's Carol Chamberlain in for the lovely Leza live on the News 103.5 KYCA. I am so happy to have a good friend and a savior, Dr. Nisha Tung, an electrophysiologist with YRMC. And I believe you are a self-described electrician of the heart.
Good morning. Yes, I am. Thank you for having me on board.
Oh, I am so happy. And before we go any further, I have to say that my husband Ken says hello and thank you.
Oh.
So we know, first of all, tell us what an electrophysiologist is, and then I want to go back from there and talk about how you got there. So what is an electrophysiologist?
So I'm a cardiologist that is super specialized in electrophysiology. Basically, it's the heart electrician.
Uh-huh.
So there are different kinds of cardiologists.
Mm-hmm.
You do internal medicine, and then you go into cardiology. Once you specialize in cardiology, you can then further branch out or just be a general cardiologist. So branching out can be the plumber, that is the interventional cardiologist, or the electrician, that is myself, the cardiac electrophysiologist.
And what made you want to be an electrician?
Well, I wanted to be a plumber, to be honest.
Gotcha.
So we have a lot of family history of coronary artery disease.
Oh.
Coming from India, that's very prevalent. And then my sister ended up with cardiac arrest. So I switched over from being the plumber to the electrician because of that.
So, first of all, why in India do so many people have heart issues? Do you know?
It's genetic.
Oh.
And I think a little bit about the diet, even though most of the Indians are vegetarians.
Oh.
They love to eat fried food.
We were just talking about fried chicken a minute ago, saying we probably want to watch that. Okay.
And a lot of sweets. So diabetes runs a lot in there, hypertension, high cholesterol, and all that leads to heart disease.
Okay. So you made this decision later in life. You were born in India.
That is right.
And when you were a girl, what did you want to be?
You don't want to know that.
Oh, yes, I do. Yes, we all do, because this is a profile on Dr. Tung. So what did you want to be then?
So there was two aspects. One is I wanted to be a physician. The other one, but I wanted to be a neurosurgeon.
Oh.
Growing up. I think it was just glamorous, neurosurgery.
Sounds good, doesn't it?
The other thing was I love to take care of people, and I love to serve and help. So they used to all make fun of me because my older sister is the physician, also the one who's sick. And they would say, oh, she's going to be a doctor, a good doctor, and the younger one is just going to be serving in some restaurant as a server.
Well, congratulations. You made a better choice because you went to medical school and did your internship in India. Is that right?
That's right.
What brought you to the United States?
Again, the same sister of mine. So my sister was 2 years older than me. So she had already come to the U.S. and it's just the two of us and my parents, of course, at that time. So she wanted to have me with her, and she's always been like a role model for me. So whatever she did, I followed along in suit. Oh. Yes.
So she came, and she was what kind of physician?
She's a nephrologist, a kidney specialist.
A kidney specialist. And what does she do now?
Well, she's disabled with severe brain damage from her cardiac arrest.
Oh, my gosh. It is heart-rending to hear something like that, to go through all her life of training and then at such a young age be debilitated by a cardiac arrest.
That's right.
So no wonder you want so much to help people who have these heart issues.
That is true.
Okay, so I'm going to back up a minute and say we know that you went to medical school and did your residency or your internship in India. North Dakota? How? Why?
Again, goes back to my sister. So my sister was finishing up her third-year residency in internal medicine in Fargo, North Dakota. And by the time I came to the U.S., I had missed my interviews for residency.
Oh.
And she is I mean, I can't thank her enough. She found out, or her friends found out, there was a position open. Otherwise, I would have lost a complete year.
Oh, wow.
And there was a position open, and I interviewed, and lo and behold, I got it.
Oh, that is fabulous. So how old are you at that time?
I was 26.
Oh, 26. So after North Dakota, where did you travel?
From there, I went to Indianapolis.
Uh-huh.
I was in North Dakota for 1 year.
Mm-hmm.
My sister went for her fellowship in nephrology to Indianapolis. And again, I followed her along.
Wow.
And I did my second and third year of internal medicine in Indianapolis, Indiana University. And then I went to Mayo Clinic for my cardiology fellowship.
Mayo in
Arizona,
Phoenix?
yes,
Okay.
in Phoenix.
Okay. So, and then after that, you decided you want to further specialize.
Yes.
And that's when you went to?
I went to UCLA to do my EP fellowship.
EP,
Electrophysiology.
So you have been around the world preparing yourself to come to Prescott, Arizona.
Imagine that.
I know. So I now have heard all around the country, all around the world. How'd you get to Prescott? What brought you here?
Well, I was coming here. I had my private practice in Phoenix, and I was coming up here to the underserved areas. Prescott was considered underserved.
Let me just pause for effect for a moment. Prescott is definitely underserved when it comes to physicians. So go ahead.
So I was coming here, and I was also going to Flagstaff and to Lake Havasu and doing outreach clinics
Wow.
to provide electrophysiology care. And then the patient, because we didn't have any of the services here, so I had to take all the patients down to Phoenix for procedures.
Wow.
And then I did follow-ups and visitations here in Prescott.
Wow.
So I was coming to the YRMC office on Ainsworth, and I did that for 3.5 years. And then the administration reached out to me and asked if I could just move up here. I giggled initially.
And a good giggle it is, let me just point out to you.
Because there was nothing. We didn't have a lab or a OR where I do my procedures. It's very specialized. So I asked them how they were expecting me to come and move here if they didn't have anything set up. So they said, okay, tell us what we need to set this up. And that's how this whole thing started.
Wow.
Right.
I tell you what, when you think about what it took, first of all, to get you, and then to get you what you needed to provide the service that you do, is really an incredible feat.
Yes.
Thank you, YRMC. Because
yes, they did a great job.
they did do a great job, because when I first started having trouble, I went down to Phoenix because that's where you go when you need a specialist. And then I kept having this problem, and I talked to John Amos, who was he was on our board at the Arizona Community Foundation of Yavapai County. And John said, "Why are you doing that? You need to come up here. We are the premier when it comes to taking care of hearts." And that's thanks to Dr. Nisha Tung. So he got me to you, and it's just amazing what we have here because of you.
Oh, thank you.
Well, thank you. But I'm going to take us back for a second, because it's pretty interesting to me that as much as you do, and we'll get to what that is you do, you also have time to have hobbies and to have a family. So there's this very handsome young man who, the last time I saw him, was about 1.5 feet shorter than he is now. So tell us about your family.
Well, my son is here. He decided to just join me today.
And happy we are to have him.
So his name is Gulraj. He's 15 years old, and he's going to be a sophomore at Basis Prescott.
Mm-hmm.
Thanks to Basis, he's here. It's an awesome school.
Does he play basketball?
A lot. Too much.
He looks like he's going to go to have a scholarship to some university for basketball. Okay, so what are your hobbies?
Other than working?
Which surprised me that there are any listed at all, but there are a lot. I mean, you play tennis?
Yes. I love to hike. Actually, I love to hike quite a bit. I've done 50-mile hikes at one time after clinics, all the way to
Wait a
Grand
minute.
Canyon.
After your clinic,
After a full 40, 50 patient clinic, yes, driven down to Grand Canyon and done rim to rim to rim, 50 miles nonstop, and then driven back. Yes, I'm crazy.
Well, no, it just sort of takes my breath away. I can only imagine. But the other thing I know about you is that you danced for Dancing for the Stars for the Boys and Girls Club of Central Arizona. And at the time, I was seeing you pretty often. And I would come in and you'd say, I was practicing at 1:30 this morning. So you are just a phenomenon. How was that dancing experience?
Oh, it was wonderful. It was just wonderful. It was a great experience. Something I had never done before. So,
oh, yeah. And you were beautiful. You were beautiful during that dance. I am seeing now that we have to take a break, which we're going to do. And then we're going to come back and talk about some of the things you see in your practice as an electrophysiologist. So we'll be right back. Good morning again. It's Carol Chamberlain for the lovely Leza Live on the News 103.5 KYCA, talking to Dr. Nisha Tung, an electrophysiologist at YRMC, who's had an amazing life. And now I want us to hear about the electrical system of the heart. Can you sort of walk us through what happens to make our heart beat?
definitely. All right. Here's the tutorial now.
No pictures. We are live streaming, but no pictures.
So there are 4 chambers to the heart. The 2 top chambers called atria, and the bottom chambers are called ventricles. So there's a squeezing action, that is the ejection fraction. There is the flow, that is the blood vessels, and then there's the electrical part. So we're going to just talk about the electrical part, and all of that plays together when it works.
So that's the plumbing and the electricity.
Yes. So the electrical part starts for all of us. We're all born with a pacemaker in the heart, in the right upper chamber. From here, the electrical wiring starts, goes to both the upper chambers, then goes through what I call as the AV node, or the gatekeeper. So the gatekeeper is the one that communicates between the top chambers and the bottom chambers. Whatever goes from the top to the bottom goes through that gatekeeper. So every heartbeat goes from the top to the bottom chambers at the same time. And when the bottom chamber beats, that's where your pulse is felt. So most patients think, oh, my top is beating and that's my pulse. No, it's the lower or the ventricles. When they contract, that causes the pulse. We all have normal rhythm, hopefully. But when you don't have normal rhythm, that's when you end up seeing me as the electrician. So the top chamber sometimes can go really fast, and there are different arrhythmias. Arrhythmias, people perceive them as palpitations or irregular heartbeat or fast heart racing. You can have multiple different kinds. If the top is going fine, but the bottom starts beating fast, it's a dangerous rhythm. That's called ventricular. And that is when people can have sudden cardiac death. And that's where you end up with a defibrillator or you pass away.
Okay, so if you have atrial fibrillation, it's just sort of the atria are just sort of fluttering around. And the ventricle is still doing its job, but not being talked to by the electrical system that originates in the atria. Is that right?
It is being run by an irregular rhythm. So the normal rhythm is from the SA node of the pacemaker, whereas when somebody's in atrial fibrillation, instead of your normal heart being going at 60 to 100 beats a minute, you could be going at, the top can be going to 400 to 600 beats a minute. But then that gatekeeper, the AV node, is the one that communicates between the top and the bottom, and it's the one that says, hey, back off. I'm not going to let all of you come down to the bottom chamber because that would be sudden death if the bottom chamber goes at 400, 600 beats a minute.
Gotcha. Okay. So how does that feel when somebody first experiences atrial fibrillation? Does everybody feel it? And what is that feeling?
So you can have different symptoms with AFib, or some are totally asymptomatic, meaning have no symptoms at all. Mostly when patients do perceive atrial fibrillation, they'll feel their heart racing or pounding, being very irregular and erratic. Some can just feel very short of breath. Some patients can have significant fatigue because their heart is beating so fast that they cannot keep up with the level of activity. And sometimes patients may just feel that they go into congestive heart failure or having anginal symptoms where they start having chest pain because their heart is racing.
There are a lot of things that can happen as a result of that. So when I was an emergency room nurse 100 years ago in Chicago, it was a large hospital. We used to get a lot of abdominal aortic aneurysms come in so we could prep them for the OR quickly. We maybe saw 2 cases of AFib a month, maybe at top. Today, everybody's neighbor, or everybody has 3 or 4 neighbors in their neighborhood with AFib. What happened?
So I think most important is people being more educated about this and more well-informed. Google.com, great. Dr. Google.
We all do. Dr. Google.
The incidence and the prevalence of AFib is increasing as time goes by. It is predicted in 2030 about 12 million U.S. citizens will have AFib. 12 million.
Well, I would have thought it was already at 12 million
Right.
just because it sounds so prevalent.
So 1 out of 4 adults have AFib now.
Wow.
Imagine. Yes, it is job security for me.
It is certainly job security. So do you think it's because of our aging population?
Yes, people are living longer. So the longer you live, every decade, above 65, your AFib incidence rate goes up 2-fold.
Oh.
Mm-hmm.
Okay. So
Sleep apnea.
Sleep apnea
Very
is a big cause of it.
A big cause which people don't understand. So bad dietary habits leads to obesity, hypertension, diabetes, gets sleep apnea worse. All that then causes AFib. AFib and sleep apnea go hand in hand. Alcoholism, a very big cause. Stress, life stress.
Okay. I think that this is it's just amazing news to me that all these things can cause AFib, many of which I had. I want to take this opportunity to say that people can call in and ask a question of you at 928-541-1016 because it's a great opportunity to be able to talk to a specialist. So we're going to take a break right now and be back right after this. Again, it's Carol Chamberlain in for Leza live on the News 103.5 KYCA, talking to Dr. Nisha Tung, electrophysiologist extraordinaire. So now we know what it is. We know what causes it. So let's talk about what a person should first do. If they feel an irregular heartbeat or some of the symptoms that you're talking about, fatigue that goes along with nothing, what do they do?
So, I'm going to back up a little bit.
Okay.
So for everybody who's listening, how do they find what's going on if they don't have symptoms? Best way to do this is to monitor themselves on a day-to-day basis.
Okay.
And how do you monitor yourself? You can have a Fitbit. You can have these recent smartwatches that can tell you if you have AFib. You can just do your blood pressure monitoring at home because people forget when you do a blood pressure, you can also see what your heart rate is doing. Mm-hmm. So when we're talking about AFib, patients normally come to me and they say, oh, my blood pressure was this. My upper number was this. My lower number was this. And I always ask them, what was your pulse? Pulse or your heart rate? Mm-hmm. If your pulse is nice and normal in the 60s and 70s, nice and beating regular, like duk, 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 that's normal. But if it starts going duk, 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 tick, 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 tick. That is AFib.
I'm familiar with that one.
Yes. So that's how you know. So normally when you are in AFib, your heart rate will go up. So if your resting heart rate is, say, 70, and it suddenly sits in 90s, 100, 120 at rest when you're doing nothing, there and right there, you know that's something going on with your pulse rate, and you need to go in and get it checked out with your primary care.
So, first of all, some people have runs of this and then it goes away and they just think, oh, there's nothing to it. Is there nothing to it? Or if you experience that, do you see about it right away?
So yes, that's a very, very good question. AFib, unfortunately, over time gets more and more frequent and lasts longer. So there's 3 different things we talk about when we are in AFib. We call it paroxysmal, which means it comes and goes, lasts for a little bit. Initially, when it starts, people don't even remember that because this one episode happened way back 6 months, a year ago, and you say, oh, I've probably had anxiety. Then it goes forward and it happens more frequently. It starts lasting longer. Longer meaning from 2 hours to 6 hours. And then the frequency starts becoming more and more and more. You don't want to miss out on that period because that's your golden opportunity to get it fixed. As you wait longer and longer, it will just stay on all the time. So that becomes permanent or persistent. There is treatment. Go ahead. You had a question?
No, that's it.
Right.
So if in fact you have this, how do you do it? Fix it.
So you go in and you see your primary care who'll refer you to a cardiologist and hopefully send you to the electrophysiologist. There are some drugs that you can be prescribed. Drugs don't have a 100% success rate. There is no 100% success rate for AFib, unfortunately, but there is cure for AFib. The initial drugs that patients will get prescribed will be something to slow your heart rate down, like a beta blocker, calcium channel blocker. All right. That is just to slow your heart rate because your top is going at 400 to 600. If your bottom is going really fast, you want to slow it down. And these medicines work on the AV node or the gatekeeper. Then you see a specialist. You ask for a specialist if you don't get referred to one. And the specialist would be a cardiologist or directly to an electrophysiologist. So in our emergency room, what they do is they directly refer to me because they know there's going to be time wasted going in between. At the end, you're going to see me.
And let me just say again how lucky we in Prescott are to have this available to us.
Yeah, thank you. So what do I do? Or what does a cardiologist do? I do a little bit different because I can provide therapy for it, that is the ablation. But there are drugs. Sometimes we try and give you drugs to see if we can keep you in normal rhythm while we're waiting to do the ablation.
So what percentage of people can be controlled with medication?
So the medications, the drugs that we're talking about, those are not the beta blockers or calcium channel blockers. Those are called antiarrhythmics. So they are rhythm controlling medicine drugs that try and keep you in normal rhythm. They work about 30% of the time to keep your normal rhythm. Yes, so it's not a great cure. Now the history is in the past you had to fail 2 medications, antiarrhythmics, to be able to become a candidate for an ablation.
Oh, really?
That is, yep.
Wow.
Then they became this because AFib ablation 20 years ago was not that great. And I have been practicing for almost 20 years. So that's my time of training. So you can do the math if somebody's smart enough to know how old I am.
Got it.
But as time went by, we started learning more about AFib, what the triggers for AFib are. And the triggers for AFib come from these 4 pulmonary veins. Those are the vessels that bring the blood from the lungs, clean them up into the heart on the left upper chamber. And those start firing rapidly. So we are going after those veins to get rid of your AFib. However, as time goes by, we say the statement, AFib begets AFib, meaning the more you have, the more it's going to happen. And the reason is because the chamber starts to dilate. There is fibrosis, there's intracellular changes in the wall of the atrium, and that causes more AFib. So you don't want to wait that long. That's why you want to come in. So what is the last part? Last part is to do an ablation. Sometimes patients may be set up for a cardioversion, that is the shock treatment to shock you and put you back to normal rhythm, which is just a Band-Aid.
definitely just a Band-Aid.
Just a Band-Aid, because it's like a big cut.
A shocking Band-Aid.
Right. And it's just going to bleed again, or it's going to go back into AFib, right? So that's why the last part is what I do is to do the ablation, where I go in with special catheters into the heart from the groin and go and fix the AFib and take away the triggers that are causing AFib.
Okay, so you take a catheter. This to me is just absolutely amazing to visualize. You take a catheter, go through a vessel in the groin. You have a camera so that you can see. And then what do you do? What do you see when that camera's in your heart?
All right. So we put multiple catheters from the groin. And when we go in, we also have an ultrasound catheter, again from the groin, called intracardiac echo. These catheters have special, when you go in for an EKG or an electrocardiogram, they put these stickers on your chest and those electrodes, and they can see what your electrical signals are from inside the heart. The catheters are specialized, and they have electrodes at the tips, multiple electrodes. So they can record signals from directly inside your heart.
Wow.
So when I'm doing a procedure, I have 8 or 9 screens that I'm looking at. So I'm looking at your intracardiac recording to see what your electrical signals are, where they're coming from. I'm looking at your ultrasound, the hemodynamics, the arterial blood pressure monitoring that the anesthesiologist has put in. I do X-ray live, and it's a lot of stuff.
A lot of stuff.
A lot of stuff.
So can you actually see where the heart is firing? Because it's misfiring when you're in AFib, and it's just going hither and yon. Can you see that?
So it's not that I'm cutting the chest open to see it. Right. This is all going from the groin. So it's a minimally invasive procedure. The catheters that I'm placing are the ones that are telling where the signals are.
Okay. So we'll talk when we get back from this short break, and we have to get to it, and we'll talk about what you're doing in there after you see what you see. We'll be right back. Good morning again. It's Carol Chamberlain on KYCA, the News 103.5, filling in for the lovely Leza Dandos and visiting with Dr. Nisha Tung. So you're in the heart. You've got these cameras on. What do you do next?
So there's several things I do. So I do a full electrical study of the heart that is called electrophysiology study. So I'm looking at all the electrical wiring, finding out where there's misfiring. So that's the first part, because you can find more than one thing going on that you may not know of. Then I go and fix flutter, which is a circuit in the right upper chamber, because that coexists with atrial fibrillation. After that, I go across. So I do, this is called drive-through procedure, where I do the right flutter ablation, which not everybody does.
Just like McDonald's.
Then I go across the septum, which is the wall between the top chambers, poke a little hole that closes on its own, nothing to worry about. It's how we do this procedure. Come into the left upper chamber, go into those veins, and I freeze in those veins using cryoballoon ablation. So there's different modalities to do it. There is heat energy, freezing, or the cryo. There is a new technology called PFA, which is pulsed wave. There's some laser stuff that has happened in the past. But irrespective, bottom line is to get rid of the circuits or the triggers for atrial fibrillation.
Excellent. We are going to stop right here and take a very quick caller. We have Tom on the line. Tom, you're with Dr. Nisha Tung. Good morning.
Well, good morning. Can you all hear me okay?
Yes, we can.
Good. I'm Tom Cheddar. I host Drive Time every Saturday morning on KYCA. And I am calling in because I have AFib. As far as I know, I've had it for like 10 years. And it's being treated with a drug called flecainide.
She's nodding her head.
Yeah. And it seems as though the episodes are becoming more frequent. We moved up here to Prescott about 5 years ago, and I really would like to hook up with you and let you check me out and see what you recommend.
Well,
so
I'm going to just...
What I'm trying to get is your contact information, actually.
That is absolutely wonderful. I'm going to ask you to give the phone number if you have it off the top of your head, Dr. Tung.
Good morning, dear. It is 928-445-6025.
Okay.
And Tom
928
is going to
445 6025. And what's the name of your practice?
It is YRMC Dignity. It's the big OSB building, the 3-story building with glass windows on the YRMC West Campus.
Oh, so you're right at YRMC.
Yes, second floor.
So I'm going to tell you to call that number, and you will have a fabulous experience with Dr. Tung. And she's going to tell us next what will happen to you after she might do an ablation for you. So thanks for calling.
I want to hear about that. And could you spell your last name for me and for all the listeners, by the way?
It's T as in Tom, U, N as in Nancy, G.
Tongue.
Tongue, like tongue in your mouth.
Well, it's pronounced like tongue in your mouth. Yes.
Well, thank you for taking my call, and I hope I wasn't too intrusive on the show, but I was afraid you weren't going to get this information out.
Oh, well, you're very kind to remind me to do that. So thanks for calling, Tom. And we're going to ask now about what happens if the first ablation doesn't work and you repeat with AFib.
Yes, you can do a second ablation. Sometimes you can end up with other kind of arrhythmias called scar flutters, which is a total different circuit because the chamber is so remodeled that just like it caused AFib, it can cause other arrhythmias, and we can go in and fix that. If somebody does not have a successful ablation because the atrium is so remodeled, again, remodeling is bad for your heart, not your house, but your heart. If it is so remodeled, then the last option is we can end up putting a pacemaker in, because if your heart is going too slow and too fast and we cannot really control your heart rate, we can put the pacemaker in for slow heart rates and give you more medication for fast heart rates. The last thing that we can also do is to do a Watchman procedure or a left atrial appendage occlusion procedure where you don't have to be on blood thinners because of risk of stroke. So if somebody's got bleeding disorders or fall risk or any of that where they cannot be on blood thinners because of stroke risk, we can put this device in and take you off blood thinners.
You bring up a great point here. One of the most important things to learn from today is how you have to get your AFib treated, because if you don't, what's the worst outcome besides death?
Right. So AFib it doesn't cause death right away, but it can cause some other problems. Tachybrady, that is slow and fast heart rates we just talked about, it can cause congestive heart failure. And that is a bad thing, because when your heart is racing so fast and not well controlled, it can put you into heart failure that you may end up needing more things done, like a defibrillator, and all those things, of course, I have to take care of. So it depends. We always say we don't want to proceed, and we want to prevent things from happening where we can catch you sooner and fix you sooner. That way we can be taking care of you in a timely fashion.
And truthfully, one of the horrible things about AFib is that if it's not treated, your heart doesn't pump effectively, and then all of a sudden it pushes out a clot that has formed in the ventricles, and you end up having a stroke. That's why people are on blood thinners, is that right?
That is right.
So nobody wants to have that happen. So I'm going to say this has been just such a fabulous time with you. And I do appreciate your coming in to visit with us, Dr. Tung. And all of you out there, if you have this experience, it is so very important to see somebody like Dr. Tung. Because one of the things I read about Dr. Tung is powerful love and compassion as a healer, family member, and leader in our community. And I can tell you that's the truth. Thanks so much for being with us. You'll be back with Leza Live on Monday. See you next time.